Welcome. We will discuss the pricing of medical options, presented as a poster to the Academy of Managed Care Pharmacy 2008 Educational Conference in Kansas City. We answer the question of how health insurance can be bought and sold between providers through the use of medical options contracts in a local market. Can such an insurance model be implemented? How should we price it? And what would be the benefit of such insurance between providers? You will see one preliminary conclusion of this work. As the insured medical practice improves health outcomes, the cash flow from the insuring medical practice improves as well. Let's begin to explore this relationship. In the course of chronic disease, costs rise exponentially and traverse through a series of progressions. Risk factors present as a diagnosis or symptoms, warranting treatment modalities. These modalities may fail, possibly leading to hospitalization. This may subsequently lead to disability or long-term care needs. A series of providers will interface the patient as they move along this natural progression of their disease. The health plan sits in the center and interfaces with each of these providers to manage the cost and risk of this progression. What if, instead of the health plan sitting in the center, we had a market dictating how and at what cost and manner a patient's progressive illness would be managed? This could be accomplished through the buying and selling of insurance between these providers through the use of medical options contracts. The following describes how we would price such insurance between providers and what might be the benefit of doing so. Before we discuss further, let's do a brief review on options contracts. What are options? An options contract is a financial vehicle that gives the right to buy a representative product or service at a guaranteed price. There's an expiration date to the contract. Finally, to have this contract, one must pay a premium. In essence, all insurance, including health insurance, is one large options contract that represents a whole series of products and services that you can get at a guaranteed price, like a copay or a deductible. There's an expiration date, typically 1 year, and you have to pay a premium. The medical options contracts model is really the same as existing health insurance, but allows for contracts written on single or combinations of products and services as the market sees fit to buy and sell between providers. The following gets into the details of how such contracts could be established. This is a simple model of a long-term care facility who would insure a hospital against a long-term disability and outcome, for which the hospital would pay a premium. This insurance would be transacted through a medical options contract. The LTC would give the hospital the right to admit a maximum number of patients, each at a guaranteed fee for a period of time, until the expiration of the contract. In order to have this right, the hospital would pay the LTC facility a premium. Now, you may be asking yourself, why would a long-term care facility bother selling such a contract? And why would the hospital care to buy such insurance? This example addresses that first question, answering what might be the benefit to the LTC. There's an additional example following this that addresses the second question, when we make this model a little more complicating. Let's focus on the first and answer what might be the benefit to the LTC facility in selling to the hospital a medical options contract guaranteeing a fixed admission fee per patient for a maximum number of patients. First, we need to answer how we might price this contract. The goal of the LTC facility in constructing this contract is such that by guaranteeing the admission fee and maximum admissions, they may still achieve a break-even cash flow. Hypothetically choosing values, suppose the LTC wants to guarantee to the hospital $700 per admission at a maximum of 50 admissions. At most, it could accrue $35,000 in revenue. However, it also has to accrue a greater $60,000 in costs. The price or premium of the contract would allow the LTC facility to guarantee this admission rate while achieving a break-even cash flow. The benefit accrues when the actual admission rate is less than the maximum, where at the other extreme it is zero, such that despite zero revenue and existing sunk costs, it achieves a cash flow due to receiving a 10% return when the LTC invests the contract premium. The solution is therefore the difference in cost and revenue discounted at this rate of return. The hospital would provide the $22,000 to the LTC to purchase the contract. These funds would allow the LTC to guarantee to the hospital a fixed rate and maximum number of admissions while achieving a break-even cash flow at this maximum. The following is a Markov model simulation involving a single LTC facility selling this contract to two different hospitals. Each of the two hospitals has different rates of performance. The first hospital is poorer performing and has a 40% end outcome disability requiring long-term care. The LTC in this simulation earned a mean cash flow of approximately $4,000 from selling this contract to the hospital. The second hospital was better performing at a 20% end outcome disability rate, leading to higher cash flow yield to the LTC facility of a mean $10,000. We therefore answered the question of what might be the benefit of a LTC selling this type of insurance to a hospital. Not only that, we find that when the LTC sells this contract to a better performing hospital, it earns a higher cash flow. We now need to ask the question, what might be the benefit to the hospital in buying this type of insurance from the LTC facility? By doing so, we need to add a new actor to the network, the primary care provider. Here, the hospital sits between the primary care provider and the LTC. It writes a contract guaranteeing to the PCP a fixed rate of admission to the hospital, as well as a maximum number of admissions. It also guarantees to the PCP that it would cover the cost of all long-term disabilities resulting from its care. As in the previous example, the price of this contract, at least in part, takes into account the fixed admission price of $35, again, hypothetically, and admission census maximum of 100. This would yield a maximum revenue for the hospital of $35, yet still at a higher cost of $6,000. Therefore, as previously shown, the premium would allow a break-even cash flow. The premium would also allow, in the other extreme of zero admission and revenue, despite some costs, a positive cash flow. However, not only does the contract involve the hospital's own utilization costs, but also the costs involved in acquiring the LTC option, discussed in the previous example and maximally exercising that contract. The option price or premium is therefore a hybrid of the two. It buffers the difference of the cost over the revenue plus the cost of acquiring the LTC option and maximal exercising. Calculating from hypothetical values, these costs are discounted at a 10% rate. Yielding a premium cost of $63,000 the hospital would receive from the PCP, the hospital would use these funds to purchase the LTC option on behalf of the hospital and allow a break-even cash flow from its own maximum census. A Markov model simulation was performed again for this three-actor model involving the LTC, the hospital, and the PCP. As previously shown, we find that the LTC earns a higher cash flow from the better performing hospital. The 30% LTC emitting hospital yields for the LTC a cash flow mean of $7,000, while the better performing hospital at a 15% admission allows the LTC to yield a mean of $12,000. Yet the hospital itself earns a cash flow reflective of its own performance, such that the better performing 15% emitting hospital earns a mean $10,000 greater cash flow than the poorer performing 30% emitting hospital. We answered the question of how one medical practice may sell to another medical insurance in the form of medical options contracts. We answered how such organizations would price these contracts between providers. We also determined the benefit of doing so. That benefit is by selling to a better performing provider, an organization may earn a higher cash flow. We found also that in the context of a network market of medical option contracts, an organization's better performance also allows itself to yield a higher cash flow. We thus have an intimate coupling of health outcomes with financial outcomes. In conclusion, you may be asking the question, therefore, why call this the pricing of medical options? Why is this not the cash flow for medical options? Well, organizations do not earn cash flow in a vacuum, but rather provide their shareholders a dividend or reinvest in the firm to increase innovation or develop new economies of scale. This lowers costs, improves performance, and thus further lowers the medical options prices. We therefore have the framework for not only an intimate coupling of health outcomes and cash flow, we also have the framework by which health outcomes is communicated through the price. This forms the basis of a price system in healthcare that is the making of an efficient and value-competing economy. I'd like to acknowledge the support of the University of Maryland School of Pharmacy, Student Government Association, and the Maryland Student Chapter of AMCP. I would like to especially acknowledge the individuals listed, as their support of AMCP's next generation has helped me in developing this work. To learn more, visit medopi.com. That's MEDOPI.com. Thank you for your time.